Welcome to the Gynarchy Podcast. This is your host, Dr. Gynarchy Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Gynarchy Patel. And today we are going to be talking about what to expect in labor and delivery with Dr. Jennifer Lincoln. Dr. Lincoln is a board-certified OB-GYN who is passionate about helping women understand their bodies and feel empowered to advocate for themselves. She practices as an OB hospitalist in Portland, Oregon, and uses social media to educate and advocate. She is an author, media contributor, and past president of the Society of OB-GYN Hospitalists. She received her undergraduate degree from Washington College, her medical degree from Tulane University School of Medicine, and completed her residency at Oregon Health and Science University. Her second book, The Birth Book, An OB-GYN's Guide to Demystifying Labor and Delivery, was just published in March 2026 and is available for order now on her website, drjenniferlincoln.com, or wherever you find books. Welcome.
Thanks for having me. Yeah, appreciate it.
Oh my gosh, I am so thrilled. I feel like I have been kind of, stalking you in your DMs for a few years. So I'm thrilled to have you.
No, I'm so excited. No, and I've never felt stalker vibe, although those of us who are on social media know that we get some interesting messages.
Yes. I didn't want to be, I didn't want to exchange any internet porn or anything.
There wasn't an emoji. I was like, wait, what are they trying to say now?
No. I just wanted to chat with you. So I'm thrilled to have you. And I have your book here. Congratulations
on this
beautiful book.
I appreciate it. Thank you.
So, tell us a little bit about how you came to be doing what you're doing. I always like to hear that, how you came to become an OB-GYN and then, kind of your journey to this.
Yeah. I was one of those weird kids that grew up always knowing I wanted to be a doctor. So I just start with that, which is then when my own kids are like, they don't know what they want to do. I'm like, but you're in height. How do you not know? You're in the fourth grade. I already had a career plan, but that's what I did was normal. And I knew I wanted to be an OB-GYN when I did my rotation. So I went to Tulane, like you said, but we were there during Katrina. And so we ended up in Houston for some of our rotations. And I did my med school rotation in Houston, Texas. Yeah, at Ben Taub Hospital, which if you've rotated there or no, it's like the big county hospital. So many births, so many deliveries. And I was like, well, if I can love this when I'm going through like the insanity of a hurricane and life after that, then probably I would like this. And it turned out to be true. And I currently work as an OB hospitalist on labor and delivery. And so love to educate, love to make things simple and take things that are complicated and break them down. And in our world where we're running into emergencies or the first time we're meeting patients is when they're in labor, it's a really fun challenge to do that. And so I thought, well, I should, make social media posts like that, use the same kind of skill set. But then I wanted to write this book because up until this book, there has not been a book that just focuses on the baby coming out part written by an OB-GYN, and that felt like a small gap. And this book is like 300 and something pages just on the birth part. So, because some folks are like, well, why not write about pregnancy and birth? And I just felt that I see patients who show up who just don't know the nitty gritty or even the things they can ask for. And it's not because their doctors and midwives aren't trying. There's just no time in these super short appointments. As I'm sure you remember, like you get a few minutes and you have to talk about so much. And by the time you get to the time to have your baby part, we just don't have the time. And patients are trying to find information. And sometimes there's good stuff on social media and sometimes there's not good stuff. And then when you come in either afraid because you've seen the bad stuff or you have no idea, you don't know what to ask for. You don't know when to speak up. And you're much more likely to leave that birth feeling traumatized and unheard. So I wanted to give people something they could go to time and again to reference and to understand. So I tried to keep it thorough, but simple and readable.
Amazing. So, okay, just to backtrack a little bit, like, do you want to explain what an OB hospitalist is,
Hmm.
just in case someone hasn't heard of
Yeah.
that?
Yeah, so it is. It's like a newer term, although I think it's getting more common. But it is an OB-GYN who works only in the hospital. So for me, I just do the OB part. So I am on labor and delivery. We do 12-hour shifts. We are there, every program, set up a little differently. But at mine, we care for all the patients who come in who don't have a doctor or a midwife. Maybe they're transferred in, or they don't have privileges at our hospital, or they don't have prenatal care, or if they're transferring in from home. We also help with all the emergencies. We assist all the private doctors if they're in their office or at home and they're sometimes babies just come out. We help with that. And we also do a lot of the
Okay.
simulation, the teaching. And the one thing that I really love too is we work with the high risk OB-GYNs or the perinatologists. So when they're not in house, we're managing those patients. So it's it's so silly sometimes how different the days can be and how stressful they could be, and the adrenaline, but it's
Yeah,
also really
yes.
fun because no 2 days are the same. And when we're at work, we're at work. So we have no other
Mhm.
responsibilities, unlike a traditional OB-GYN who might be in clinic and then their patient goes into labor. So what's great is we help to really focus on safety because there's always somebody physically present on the unit. And when things can change very quickly, we're there. And I think the nurses really appreciate
Mhm.
that.
Interestingly, I also did OB hospitalist work for a bit when my children were
Hmm.
little. It was quite perfect for me because,
Yeah.
I just went and did call and was able
Yep.
to be present. And yeah, that was, I mean, in I was actually the first one in Massachusetts to ever do it, and that was 2005. So it's kind
Oh,
of
wow.
relatively new.
Yeah.
I guess just to share with people, it's kind of a relatively new kind of position. And I also
Yeah.
covered the emergency room. Did you do that?
So we don't. And I think it's because
Oh,
our labor and delivery is so
so
busy.
busy.
We
Okay.
have the most
Yeah.
babies in the state of Oregon. But yes, in some other models, you'll do both. Yeah. Hmm.
Right, right.
Yeah.
So, yeah, I feel like your book is so groundbreaking. I feel like I'm talking to somebody who is going to, like people are going to read this book for generations,
I hope
you know,
so.
kind of
Oh, thank
like what
you.
to expect when you're expecting
Hmm.
that was just, a staple. And I love how you formatted it as if, like it just has every possible question that
Oh,
we've
thank
heard as
you.
an OB.
Yeah.
And what an
Hmm.
interesting way. It's like instead of chapters, the chapters are or the sections are questions, which is just
Right.
much more intuitive for patients.
Yeah, and that's exactly, I wanted my book to feel like a search bar because I don't know about you, but when I'm trying to figure out
Yeah.
something to use for my hair or like a derm treatment, I go to TikTok and I type in the question. I mean, that's
Oh,
what
yeah.
we do and that's what patients are doing. So instead
Mhm.
of just paragraphs and like this day, like you have to figure out how to communicate to people how they consume things. And I know I do. Like
Yes,
if
yes.
there's a question, I want to look it up and be like, okay, I'm terrified to poop. What should I do? Like, there we go.
Mhm,
Instead of
mhm.
page 72 on recovery or whatever. So
Right.
yeah, I had a lot of fun writing it. It was fun.
And honestly, like afterwards, I mean, now I was just kind of shocked at how, wow, we really didn't have this book. How
Yeah,
strange.
I
How
know.
strange. Like
Yeah.
thank you, I guess.
No, you're
Like
so welcome. It would have been
we
great if
had
somebody else had written it because it's a lot, it just would have been nice if we'd had this
I
already.
know. I mean, it made me think
Yeah.
back. I'm like, wait a minute. We always had this gap, and it was just so I
Hmm.
was blind to it. Like I really thought, I think the way we educated was just childbirth classes, but they didn't have,
Right.
I mean, I'm sure had handouts and things like that you took home.
Yeah.
But how nice to have a reference on the labor and delivery experience.
Yeah. Oh, thank
So,
you.
and it's very apparent how many hours you must have spent on this. I mean, can you share how long it took you to write this?
I'm not
I'm just
trying to,
curious.
yeah, I'm not trying to be facetious. I don't think it was that much. And maybe you get it like, because, you have your news, like when it's what you do and it's what you love, like that part is very
Mhm,
easy. I will
mhm,
tell you what the hardest part, I think, of writing a book is the after part, like the marketing and the getting it out and the da, da, da.
mhm.
And when you're somebody, you're like, I don't do that every day, right? Like I operate and I help babies be born. Like I could sit here and tell you all day long what a shoulder dystocia is, and that's so simple. But what was kind of cool about this book was, since it is question and answer based, is I would just steal moments like in the morning or on a night shift when I had, a little bit of
Oh,
downtime and I could just get through it. And I was also so excited about writing it that, when you sell a book, you do a book proposal and you include some sample content. And I included quite a bit. And then I just kept going because I was like, well, I'm just going to, maybe nobody will buy this book, like, no publisher or whatever. But I just assumed, I was like, I think they will. So I just kept going because it was just fun for me. And I think that being an OB-GYN in America in 2026, there's so much to stress us out that this was like the nice distraction, or you feel like you do
mm,
something, and you probably feel the
yeah,
same way
yeah.
doing it. Like you feel like you're doing something.
Yeah,
Yeah.
exactly. Especially
Hmm.
now, yeah, yeah, exactly. We need positive ways to redirect
Hmm.
our energy and feel like we're
Right.
making an
Right.
impact.
Right.
And actually, now that you said that, I'm like, you know what? You have been educating online for years. And so
Yeah.
I guess a
Mhm.
lot of this was you sharing a lot of the content,
Yeah.
in written form that you've
Yeah.
kind of maybe
Hmm.
shared on reels or videos, right?
Right. So if you've made the YouTube video about it, you're like, okay, I know where I had those references. Let me go. And now I have to write it out. So it's definitely not the same thing. But yeah, it's helpful when you're like, I've thought about these things before. Let me
Yes,
multi-purpose
yes.
everything.
Well, yeah, and I really wanted to have you on, of course, like besides noting that you had this book out, but and to help you share this information. But right now, of course, we have this maternal health crisis going
Mhm.
on in the US, and we're falling behind all these other developed countries. And now it's just more important than ever for us to help patients be able to advocate for themselves. So, yeah, it's a good time to be talking about this. So,
Yeah, no, I agree. And I think that it's, you're like, let's talk about it, but be positive because you're right. It's harder than ever to access care. We're seeing shortages, we're seeing insurance premiums go up. And the thing is that we're all trying to fix this. We're all working in different ways to advocate. But like, if you're pregnant right now in 2 weeks and you're going to go have a
right.
baby, like, what do you need to know? And so there's a lot of
Mhm.
stuff in this book where I'm like, you shouldn't have to think about X, Y, or Z. But since you
Right.
do, here's how
Mhm.
here's how to prepare you.
Yeah, I
But
feel like
yeah,
it's a scarier time right now because of, a lot of the things going
mhm.
on, and especially depending on where you live.
Right, right, yeah. I
So,
hear you.
actually, before I get too distracted with the content of this book, you mentioned this is your second book. Do you want to share
Mhm.
what your first book is?
Yeah, so it's called Let's Talk About Down There, and I published that during the pandemic. So that was 2021, and a very,
Okay.
similar style question and answer, but it was about
Oh,
all the stuff down there. So sections on birth control, periods, sex, going to the doctor, and that was really out of my content from TikTok where I was making what I thought was very basic stuff, like here's what a period is, or no, birth control is not gonna, is not harmful in this way, and just busting a lot of myths. And it's heavily illustrated, so it's full color. So it's got a
love it.
different feel. But yeah, that was super fun too. I enjoyed doing that one too. Yeah.
Great. Okay, so let me ask you, I guess I'm curious about some of the you mentioned that you like to talk about, we have mixed information that we get
Hmm.
online. Some of it's good, some of it's bad. So I
Hmm.
guess I'm curious, like, what are some of the more harmful things you've heard online about, childbirth that you
Yeah.
were trying to dismantle or debunk with your book?
So we could talk all day, but I will boil it down to a couple. I think
Okay.
the first, and this is just so interesting because we're seeing this having to do with all of women's health, that like natural is always better, meaning that you never need medical intervention. And you and I both know that, yes, birth can be totally unmedicated and things go and it's wonderful. And then sometimes it goes a little sideways. And just this idea that you never need medical care. So people who are like free birthing or having a baby at home with no medical professionals, oftentimes they're not getting prenatal care. And this idea that like all care is harmful. And I say this on social media all the time that if something is always perceived or put forth as like always good or always bad, like that's never the case, hardly ever. It's usually somewhere in the middle. And so if somebody's telling you that, they might not have the expertise or they don't get the nuance. So I think that's super harmful. I think that what we're seeing about a lot of misinformation and really misunderstanding about things like, is Tylenol safe? What vaccine schedule should I be following? And yes, there are some vaccines that we recommend in pregnancy and in the newborn period. So I'm just seeing people who were like, where do I go for information? There's a lot of mistrust, and we saw that really start during COVID. But I think it highlighted issues that people were already feeling like they couldn't really talk to us as doctors, that it was just this like, do what I say. So then this whole other alternative movement, which has always been there, has really proliferated, and we're seeing harm. So this idea that like all interventions are bad, right? Like all inductions, all epidurals, all C-sections. And yes, I think we are over medicalizing birth in many cases, but there is a balance, and it's about having that balance and being able to ask those questions of somebody who has your best interest at heart, not somebody who's like selling you a detox or whatever, online.
Yes. Yes. Yeah, I'd love your thoughts on that some more, because on your thoughts on the perception of doctors actually on social media, and why there's been, I have my own thoughts about this, but why there's this distrust of doctors. And I often, hear like accusations that we're, just, in the pocket of pharma. And so, and I know, so yeah, I'd love to hear your thoughts on that, because
I mean,
here we're trying to give reliable, evidence-based info, and we have to fight these narratives. So,
yeah. Well, I think the sad part, and I think I've only realized this as I've been on social media more and people send me their stories. The unfortunate truth is that there are physicians out there who don't practice evidence-based medicine or don't treat, especially women, with respect. So there are people having their babies who are being yelled at by their doctors or their nurses, or being told you have to push on your back. And of course you have to have your bag of water broke. Like that, unfortunately, exists. And it breaks my heart because I work in a place where like I think we're wonderful and we're very collaborative. And I know that good people exist. But the truth is that I think we've done a lot of this to ourselves, especially in the field of OB-GYN, where women have been experimented on, have not been listened to. So I think we have to own that. And then you add in this extra layer of all the distrust that is not true. Like, I mean, yes, some people are probably making a lot of money from big pharma, but the vast majority of us are not at all. And there's just this like basic misunderstanding of how these things work. And I'm sure you see it too, right? Like you prescribe birth control because you make money every time you do it. And I can't tell you how many videos I've made where I'm like, I don't like, do you all get it? When we prescribe birth control, nobody's paying me. And I'm probably losing money every time I do that or insert an IUD if I wasn't salaried, which I am, but because we're fixing a problem and you're not coming back hemorrhaging every month, or you're not coming back having a baby every year. So there's a lot of misunderstanding, but I think that is on purpose by a group of people who don't want necessarily all the information out there or want women to have control of their bodies, which is sad. So I think it's two separate things, but both are very real problems.
yes, yes. And I like the point you made about like, I do think that looking at how people are making money is a clue, and also trying to be more transparent as physicians about how we are paid, exactly. And I think so many OB-GYNs are really just salaried,
Right. And right. Yeah. I'm making the same whether I see 10 patients on labor and delivery or 30. And yeah.
Right. And you're not getting kickbacks. And there's a way to check whether doctors are getting kickbacks, right?
Yes. Yes.
So you alluded to some of the problems of the medical system, and I guess I'd love to hear how you feel it shapes, women's birth experiences, what some of the bigger issues are. Do you talk about that in your book?
Yeah. Well, I think you just look at like how we have maternal care set up in the US, which is you have these prenatal visits, you go in this set number of time, and then we have the audacity to be like, and then come back at 6 weeks with your newborn and do all this. Where in other places, they're coming to you, or, especially postpartum, but even for some, if you're doing a home birth or whatnot, the providers are coming to you. They're spending more time. You're not just in there for like 10 minutes, four of which are when you actually see your provider. So it can be really tricky. And we also have the unique situation, or not, maybe not unique, but the real situation with maternal healthcare deserts, which is where we've got counties with no OB-GYNs or midwives. So And I hear people who say, well, I found out I was pregnant, it was 7 weeks. I called to get an appointment. I couldn't get in until 12 weeks, which is a long time. And to think that we're not seeing people until like the beginning of their second trimester or the very end of their first trimester, we lose a lot of time to really educate, to make people feel like they're seen and heard. And I know myself is like, I'm in the business. And I was told with my second, when I got pregnant and I moved back here to Oregon, I called to make my appointment. And they said, well, you don't have insurance yet. We can't schedule you. And you'll appreciate this. Because I was like, this was where I did my residency. We saw people without insurance all the time. And it's in the process. What do you mean? You can't. So of course I got in because I knew how to work the back channels. But the average person who doesn't, and then, as a hospitalist, I might see somebody who rolls into late triage at 22 weeks and maybe has just had their first visit. And it's not because they're lazy or whatever, but like, I get it. And so people have to really struggle sometimes to access good care, and it shouldn't be that way.
Right. I mean, and we have this, right. You said maternal care deserts and
Mm-hmm.
shortage of OB-GYNs, and it's only getting
Mm-hmm.
worse with these like hospitals closing and,
Right.
rural
Yeah. Because
areas.
this is super fun. And this is something I love being told. And any OB hospitalist knows this is we're told we lose the hospital money because so much of
Right.
what we do, you can't bill. And labor and delivery in general loses hospitals money because it's so labor
Mhm.
and no joke, but like labor intensive, like so many people working there. And then the reimbursement is so terrible because of how reimbursement was set up. Yet the NICU does great because they make a bunch of money.
Mhm.
But how did those babies get there? The people helping them come out, but because they decide to silo how they do the books, it looks like we're losing money. So what do hospitals do when something loses money? They close it. And then where do
Right.
these people go? And I don't know if you saw this, but there was a new study that came out that people who were pregnant having to drive or having it like
Hours.
their OB
Yeah.
provider within 30 minutes, it used to be
Yeah.
90% and now it's down to 60%. So only
Horrible.
60% of
Yes.
people have a doctor or a midwife within 30 minutes. And can you
Yeah.
imagine like if somebody's bleeding or in labor or like like minutes
Yes,
make a difference. So yeah, it's scary.
exactly. It's no wonder why maternal mortality is going up and
Hmm.
perinatal mortality. Yeah.
Yeah. Yeah.
So I guess okay. So let's talk about the some of the questions you answer in the book. They're so
Sure.
interesting. I guess I want to know what you feel are like the most, the questions you get the most that you feel like this
Yeah.
has helped to answer
Yeah. I think the
about labor.
questions I get the most, like the ones that to me, I'm like, I can't believe people still think this, but it's because, there's so much misinformation out there of like, is an epidural, like all the myths about epidurals, like, is it going to increase my C-section risk? Is it going to slow my labor down? Is it going to cause lasting issues? And that was really fun to break them down. And then anything that had to do with anesthesia, I had an anesthesiology friend who looked over that section because I had a bunch of people review this
Oh,
because
great.
I believe in the power of multiple brains. And then she even added more myths. And I was like, oh my God,
Oh,
there's just so many that I hadn't heard
wow.
of. So that was one. And then just this idea of, once having a C-section, that you always have to have a C-section. And
Mm,
so I talk about, vaginal birth after cesarean, which some people live in areas where they're told that's not an option because of the setup of the labor and delivery. And it's so interesting because the American
mm,
College of OB-GYN talks about what would be ideal, but they never say that we should not be offering it to people, even if we don't have these things like an anesthesiologist and whatnot. And I think it just highlighted that there's so many things where we have these guidelines or these recommendations, and hospitals sometimes overdo it with the interpretation and forget the part about you can inform somebody of something. But at the end of the day, they get to decide if they want to do something or not. And you can document and you can do whatever, but we have to stop like telling people like you're not allowed to do this because that I think is just that doesn't make sense to me because people are, can be have their own free will and use it. And I
right,
get that we're all
right.
afraid of medical legal stuff, but I
Mhm.
think we have to be a little more level-headed about how we discuss these things with people.
Yeah, actually I'm kind of curious about how you recommend that women, advocate for themselves on labor and delivery, because it
Mhm.
is hard. And I know that I feel like just having information and knowledge is helpful, like
Yeah.
what you provide in the book. But
Yeah.
any other tips,
Yeah. Well,
that you
no,
have
I mean,
about
you hit
that?
the nail on the head of like, you can't advocate for something if you don't know what you could have a right to. So that's step number
Mhm.
one. But I think step number two is don't wait till you're on labor and delivery. Talk to your doctor or midwife ahead of time. This is where birth preferences can be helpful because if you are met with a ton of resistance over something that's really important to you or seems like that shouldn't be, you then have the time to be like, is this where I want to be, or do I want to seek care elsewhere? And you're figuring that out long beforehand. And then when you're on labor and delivery, talking to people, having somebody there who can also advocate with you, whether it's a partner, a friend, or a doula, and just knowing that advocating in an effective way, it doesn't mean you're yelling at people or you're like, but having these conversations and seeing it as a team sport and not being afraid to ask questions or the magic words of, do we have time? Can we have some time to think about this? Or is it a true emergency? Or what are my other options? Is there more information you can give me? I just think when you come off as being engaged and involved in the process, your team should meet you there and be like, oh, this is somebody who really wants to know. Yeah, usually we always start every induction with whatever, misoprostol, but they're asking, let's talk about all the options.
I
Mhm.
love that you give, like language for patients to use, because I think it is intimidating and difficult to
Mhm.
for, ask for more information or other options. And
Yeah.
I guess, that just reminds me of just the consent process on labor and
Mhm.
delivery is a little bit like, you just sign a bunch of papers, to be frank, like I don't know that
Right.
anyone is sitting there and reading things. And a lot of times things are done without fully discussing them,
Yeah.
so yeah. How do you think that informed, how do you think that
Yeah.
consent
So like
process should change?
real informed consent where we actually people
Yes.
have time to ask questions. Yeah, wouldn't that be nice? And I
Mhm.
feel like, we try to do that. And I think some people do it more than others. It's part of why I included on my birth preferences that, I want to talk about a C-section. I want to talk about forceps and vacuum. I want to talk about a blood transfusion because you're talking about it, not when
Ahead of
we're
time.
everybody's in the moment,
Right.
and
Right.
and even sometimes that does happen, but in a regular run of the mill, you should have things explained to you, the risks, the benefits, the alternatives. You should have time to ask questions. You should have time to look at the form before we're like, just sign here. So I think reminding people that consent is a process, but as a patient, you might think that, oh, well, if I bring up a C-section now, that means they're going to think I want it. You can be very
Mhm.
clear and just say, listen, I am full court press for a vaginal birth here, but if I needed a C-section, could we just talk through that? Not because I want it, I just want to ask questions. And I think when you set it up like that, you've got like actual time to talk
Yes.
and
Yeah.
feel informed. I think
Mhm.
that's the ideal.
I did like toward at the end of the book, you give a list of questions to ask your provider to prepare, right, for labor and
Yes.
delivery. So that's
Yes.
very handy in case
Thank
you're
you. And
just
it's
like
all on my website
overwhelmed.
too. If you want, you
Oh,
can just go to my website and then you just put in your email and those will all be emailed to you as PDFs and they're all free too. So if you don't have the book and you just want them anyway,
okay.
because I love a good free
Handout.
like question.
Yes.
Yeah. Mm-hmm. Yeah.
Okay, that's drjenniferlincoln.com.
Yeah. Exactly.
Okay, and when you say birth preferences, I did see that you had
Mhm.
like a form that you could
Yeah.
fill out. Birth preferences, that means like birth plan, right? Same thing.
Yeah. Yeah.
Is there a
Hmm.
reason that you say birth preferences? Does birth
I
plan
do,
sound?
yeah. Well,
Yeah.
let's be real. Like birth plans get a bad rap, and sometimes people are like, "Oh, she's got a birth plan," and I used to be like that too.
Right, right.
And then I realized people are doing this because they feel scared and they want a chance to communicate. And
Yes.
so I think they're great. And I think language is so much, right? Especially in our
Yes.
world with failed induction of labor and failure to
I
like
know.
if I could just reinvent. So and this was not a term I came up with, but just this idea of framing it as preferences as opposed to plan. You should absolutely have preferences. And I hope they all
Mhm.
come true for you. And
Yes, yes.
just holding it a little looser.
Mhm,
And what I think
mhm.
is really important too, whether you're planning a home birth or a vaginal birth, it's great to have preferences for everything that could happen. And one of my favorite home birth midwives, when she transfers in, she makes sure that the people she cares for, they have a home birth plan and a hospital birth plan and a C-section plan or preferences. So they've thought about it. So it's not just like,
Surprise,
and I
surprise,
think that
right?
we know that when people are
Yeah.
prepared, they're less likely to be traumatized. So yeah, so that's why I call it
Yes.
preferences. So.
Yes. And
Mhm.
actually, yeah, actually thinking about it, when you say plans can fail, but preferences,
Right. Right.
that's just sharing of ideas. Yeah. So I like that.
Exactly.
You mentioned C-sections, and I guess, you mentioned like you might have a preference for vaginal birth, but
hmm
what if you have a preference to have a C-section? I know that's something you cover. So would
hmm
you like to share your thoughts on that? Since
Yeah.
we're
So, called what's the terminal? It's a
elective?
C-section on
Oh,
maternal request, cesarean delivery on
oh,
maternal request, CDMR,
mhm,
because of course we have to have an abbreviation for everything in our
right.
world. But yeah, I talk about how some people do request them. And just because you request it doesn't mean we're going to be like, yes, oh my gosh, let's go do a major abdominal surgery. And I think that there are legit reasons where somebody might want one. And after that informed consent we talked about, that might be the best path forward. So I've had patients who've had a prior history of sexual trauma or tocophobia, which is the medical diagnosis, fear of
Fear.
labor. Yeah, and we've had patients who've had that, and they've gone through therapy and whatnot, and they're just like, I can't.
Mhm.
Or certain mental health disorders where just that lack of control and autonomy is just too much. So I think there's
Even
a time and
medical
a place.
trauma, honestly.
Exactly,
Yeah.
exactly. There's a time
Mhm.
and a place, and for us to
Mhm.
villainize all elective C-sections. But yet, when somebody needs one medically, we're like, of course it's safe. Like, we have to hold both truths and
Right.
just make sure that
True.
and you counsel and you're talking, or do you want to have one kid or 10 kids or where are we at? So I think that there is room for both for sure.
I love, speaking of trauma, I love that you cover that pretty extensively in the book.
Yeah.
And yeah, I'd love for you to share your message for women who have experienced, childbirth trauma.
Yeah. And so talking about more, when we say traumatic birth, what I'm talking about is psychological trauma. So I'm not saying you had to have some horrible happen, although
Mhm.
certainly that could cause trauma, but you're not alone. 1 in 3, and in some studies, 1 in 2 people who've had
Shocking.
babies, which is,
Yeah.
it's terrible. So I want people to know they're not alone. There are a lot of people out there to help you with it. There's no one right or wrong way to process it, but you're going to have to process it at some point in order to feel that you are, at peace and doing okay. But I want people to know that you don't have to reach a threshold in a checklist to have your birth be viewed as traumatic. If you felt traumatized, there we go. And
Mhm.
it could be, yes, the like emergency C-section, baby in the NICU, hemorrhage, sure.
Mhm.
But it could also be that you showed up in labor, you were so scared that it went so quickly, and you had a baby in 10 minutes and you didn't get an epidural. Like that could be traumatizing. And if your best friend is like, what are you complaining about? It's not like you had a C-section. That's just not helpful and is
Mhm.
not going to help you process it. So I want people to know that you don't have to like prove that it was bad enough in order for it to count, and that there is help out there and you deserve to feel helped.
I also like that you cover stillbirth. And actually, I feel like
Um,
this is helpful for doctors because I don't recall anyone ever covering this in a teaching way, a didactic way. Like it was just
yeah.
on the floor when it happened.
No, same. I
And
remember getting thrown
it's
into the room and it was like a
right.
19-year-old and they're like, go manage her induction. And I just remember feeling like there has to be a better way to do this. But
Yes.
also I couldn't say anything because I was a second year
Right.
resident. So,
I mean, I would, right. We're in training in our 20s, and I had not even experienced any, even just deaths in my family,
mhm,
like even
same.
grandparents' deaths, really.
Yeah.
So, maybe one extended relative. So, I was just trying to figure out how to deal with it myself because
Yep.
I feel like it was trauma for me too.
No, it is. It was, and it
Yes.
is. And for us to have been put in those situations, I mean, I remember on my oncology rotation having to pronounce a patient dead, and she was young, and it was ovarian cancer, of course. And
Mhm.
nobody told me how. And the nurse was like, you just go do it. And I remember afterwards going in the med room and breaking down. I was like, this was
Yeah.
already sad enough, but now I feel like, because you feel like, what if we
Right.
don't do it well, right? Like we make it
Mhm.
worse for the
Mhm.
patients, and stillbirth is it's the same thing. And yeah, and I wrote this section because I don't want anybody to have to read it, but we know that it happens. And
Right.
if it doesn't happen to you, maybe it happens to a friend. And in that moment of panic, you're like, where do I go look for information?
Mhm.
I'm very lucky. I have not myself experienced a stillbirth, but we've certainly helped people with it. But I
Mhm.
had someone review it who went through it herself and now is part of a nonprofit that helps to raise
Yeah.
awareness. And I learned so much. She was like, "No, say it this way, not that way." And it's just like, why are these not the people training us in
Yeah.
residency how to
Yeah.
do
I mean,
this,
I
right?
think doctors need to read this. Yes.
Yeah, yeah.
Absolutely. So, also, I mean, I mean, I'm thinking this is a good book for partners as well, you know? So, like,
Mhm.
what's your advice for partners? What role do they have? Do
Yeah.
they play?
A huge role. I mean, they're like 50% of the genetic material of this baby that's about to be born. So like they're in it, and it's not just a, and I say that not to be facetious because sometimes I feel like partners are pushed to the side like, "Oh, you whatever, you're not going through all this," but they are. There's a lot. You're watching your partner maybe be in pain for the first time. You feel like you can't fix something. So I think we need partners in the room. We need them as advocates. We need them to be informed too. So yes, I want somebody who's pregnant to read this book, but also their partner, because together they can advocate. And I think that the other big thing for partners to know, and I talk about this whenever I discharge somebody, you have your spiel, and I say, and we talked about all these things like hemorrhage and blood clots, but the number one complication of childbirth is postpartum depression and anxiety, not just in the
Mm.
people who have the babies, but in the people who love them and who are in the partners as well. So I need you to look out for each other. And I bet you don't even have a doctor, do you? Like, when do guys go to the doctor
I
when they're,
know.
young and healthy? So I
Right.
say, I need you to look out for each other. And if either of you needs help, let us know. We'll figure it out. Because so many dads are like, well, I can't say anything, right? Because she just went through all this and I'm feeling anxious, but what right do I have? I'm not bleeding. But you do. And we need everybody. It's a family unit. So we want everybody to do
Mhm.
well.
Absolutely. So, like, give us your vision of what an empowered birth experience would look like.
Oh,
You know,
yes. Yeah,
what's
I
your
think
dream
my
that you,
dream,
yeah.
somebody comes in, they've taken the class or read a book or whatever. They have some preferences and they lead with, these are the things I need you to know about me. And I put that in my birth preferences as well. Because yes, I want to know all the nitty gritty, but I want to know, like, what are the top three things that you need me to know about you? Whether it's, I had a terrible experience last time and here's why, or I'm really scared about this or whatever. So I love it when patients and they're just like, this is what I need you to know about me. They're engaged, they're asking questions. They know that it's not just happening to them, but with them. And so speaking up and just letting us know, like, also, you've seen this, every birth can look very different.
Mhm.
And you can choose, like, do you want it to be a party and you've got everybody, or do you want it to be intimate and just go with whatever feels right for you. Don't feel like it has to be a certain way, but know that you can personalize it and have it that way and ask questions. I still find it so interesting when I'm rounding and seeing somebody, and I've learned to change my language from do you have any questions to what questions do you have? And somebody will ask a question and they're like, "Oh, I have one more. I'm so sorry." I'm like, "What are you sorry about? This is, you just birthed a watermelon out of your vagina. It's the first time you did it. You are to ask questions. That's why I'm here." So
Yeah. Yeah.
just know that. And if something doesn't feel right, please speak up. Please let us know. I don't want you to carry something, or if you're not sure, it's okay to say, "That made no sense. Please explain it again."
So what you were saying just was making me wonder if you've ever had any interesting or memorable requests from patients, for their birth experience.
Yes. One time, okay, well, playlists. I could talk about this all day long, but I think my favorite
Okay.
playlist is it was at time of C-section and it was like Metallica and Ozzy Osbourne. It was like this total metal couple. And it was
Oh,
so fun because
so cute.
when I default to like, would you like me to put some music on? And, and I'll pick like the YouTube, like nature sounds or whatever. And they were
Oh,
like, we would like Metallica. I was like, we can do because that would have been
that's so
totally terrible. Yeah.
cool. Oh my
Um,
goodness. Yeah.
and I think some of my other favorites are when little siblings are there, which I miss them so
Oh,
much during COVID. But like, and this is, you decide what's right for your family and what the hospitals are okay with and make sure, I go into all that. But sometimes it's so fun when you see the sibling and they're like, brother is here. And then we all start crying because it's just
so
like the cutest thing
cute.
ever. Yes.
Yes. Yes.
Yeah. Wait, oh, I have to tell
Yeah.
you one more
Sure. Oh
hilarious.
yeah, I want to hear them all.
Yeah.
That's what I miss, like I don't do deliveries anymore, but
Yeah.
that's on it was a little tough at
Yeah.
first dropping OB because that's really what what I feel like most OB-GYNs go into the field for is
Right.
it
Yeah.
is like such a joyous like experience and
Yeah. Yeah.
like nothing better. But go ahead.
No, it's true, but it can be crazy. So this was one time in
Yes.
residency, and it was right around it was New Year's Eve, because of course we were working New Year's Eve. And it was a couple, and it was like the change, and it was Chinese New Year. That's right. It was different. Anyway, long story short, she was bawling because she wanted her baby born during a certain year and not the other. And
Oh
I could tell,
no.
I was like, honey, there is no way this baby's coming. Like, I was setting the stage, like, you're not close, you're pushing, but we're not close. And she's like, can I just have a C-section so it can be on the date? And I was like, even that's too, like, we're 10 minutes away.
Were
And
they were Chinese and it was a more
yes,
auspicious day, the
yes,
day
yes, yes, yes.
okay.
Yeah. And then,
Interesting.
the baby was born when the baby was born, and they were begging us to lie on the paperwork. And I was like, you guys, I cannot lie on I'm so sorry. And I just remember thinking, like, I wish I could fix this and make it better, but it was just so, I've never been asked to, lie on
Okay.
paperwork, but that was
Wow,
funny.
that one has never happened to me. Interesting.
Like, you remember the room. I was like, I remember the room. I remember where everybody was. And I was like, nobody trained me for how to respond to this.
Yes, yes. And
Yeah.
actually, what it does remind me of is just like uncomfortable situations in
Hmm.
the birth room, like with people sometimes, or like, so like how do you deal with that when like the mom doesn't want certain people around and you're just
Yeah.
feeling like family members are pushy?
What's great as you have more experience? I like to say that as opposed to getting older. But I think once you like have more experience, you have no problem being like, yeah, so we're not saying that, if a guy, I
Oh,
think a guy
okay.
one
Yeah.
time said like, are you going to put an extra stitch? And I looked at him and I said, why is that a concern? Like,
Mm-hmm.
or, I think you just have no issues. And so many of us, right? We go into this field, and the nurses, like, we're very protective of our patients. So if somebody's
Mm-hmm.
acting up or whatever, I think it's very easy. And you can also, like, we all know you get your patient to go to the bathroom, and then you're in there. You're like, so tell me, what is the deal with her? Like, what do you need me to like get her out of here or whatever? So I
Yes,
feel like
yes,
we're always in our patient's corner and willing to
yes.
take whatever. Like, go ahead and hate me. This isn't about you. It's about her. So let's
Right,
focus on
right.
that. But yeah, sometimes I think it could be a reality show. Sometimes I think it
I
could
know, I know. And now that makes me think of some of the poor pregnant patients that have been in the news. And I kind of wanted you to weigh in because,
Yeah.
so the two I've been thinking of to mention to you are one,
Mhm.
Charisse Doyley, who I
Yeah.
believe, I don't know if I'm saying her name right, but she's in Florida and
Yeah.
she's the Black woman in Florida who was court ordered to have a C-section.
Hmm. Yeah.
And
So yeah,
that was going viral for a bit.
oh
It
yeah,
was really
yeah. No,
crazy.
insane. So yeah, for folks haven't heard, she was in labor, and what I think is so interesting is she was also a doula. So she's very in this world. Like, she
Yeah,
knows what's up,
formed.
and
Uh-huh.
wanted a vaginal birth. I think after having a couple of C-sections, her doctors didn't recommend it. And again, recommend, right? Guidance. It's not that you have to. And
Mhm,
long story short,
mhm,
while she's in
mhm.
labor, they brought in a judge and a whole panel of lawyers on Zoom, all white. She's Black. We're in Florida. You can read between the lines. And she ended up having a C-section and a court ordered thing. And I think, and what's actually, so I made a video about it, and she actually commented on it. And I was like, oh my God, it's you. Like, she was like, thank you so much. Like, she very much had a traumatic situation. And
Yes.
I think
Mhm.
and my take was, and I wholeheartedly believe, we should never be forcing anybody into, I will never do a
Yes.
surgery on somebody unless you fully consent. That's abusive. That's horrible. There's even an
Mhm,
ACOG document that says this. We have an FB. But
mhm.
what concerned me more were the OB-GYNs in my comments who were like, of course I would do that. You're going to let her or the baby die. And I just think that we have to step back a moment and think about,
Oh,
we would
crazy.
never force a blood transfusion on a Jehovah's Witness who declined it. I
Mhm,
would never force you
mhm,
to give your kidney if your brother was a match and he would die without it. So why, just because somebody has a fetus inside of them,
mhm,
we take away that
mhm,
autonomy?
mhm,
And I'm not here to be like, oh, it'd be so easy. No,
mhm.
we would definitely talk and we would counsel. But this idea that because you're pregnant, you lose control of your body, and we're not just
Right.
even talking about abortion
Mhm,
right now. We have to be very clear-eyed. And
mhm.
I think that, going back to earlier when I said sometimes our own field has harmed women, the idea that there's still doctors out there who think this is okay. Like we have work
I
to do.
know the
We have work to do.
training was
Mhm.
bad, if that's what they believe. Like, what
I
happened to
know.
bodily autonomy?
Right,
What
right,
happened to regarding the patient in front of us, the
right.
woman, as our primary patient?
Well, exactly. And then
That's
people saying,
wild.
well, but you could get sued. And I said, well, you could get sued either way, right? Like I hope
Yes,
she could sue just like you can sue for
yes.
wrongful life. You would sue for that. So we
Mhm.
can't let medical legal stuff completely overtake us. Yes, I know we're in the field that gets sued most often, but
Yes,
you communicate, you
yes,
document, and if you can't see the
exactly.
person in front of you, then maybe this is not the best job for you.
Right, right. And
Yeah.
Cherise Doyle is a very she's very right, like you said, she's very informed and well
Mhm.
spoken. And she shared her thought. I saw her video about it. And exactly, and she was worried about her other children. Why are we not
Right.
worried about her life and her family and her other children, living children?
Yep.
It's
Yep.
that's sort of wild.
No,
And then
completely, completely.
yes, yes. And I'm sure you also have thoughts about, I guess this I just never shut up about, but Adriana
Mhm.
Smith, you know,
Yeah. Yeah. This idea that we are seen as
property or,
incubators,
yeah, incubators,
exactly. And so
right?
being kept alive to grow a fetus, which again is completely fine if that's what the person chose for themselves. Like,
Mhm.
but I remember thinking through and what I learned, I didn't know if you knew this before then, but this idea that you can have an advance directive, but once you're pregnant
Oh,
in
yes.
how many states, it does
I
not
only
apply.
learned that. I only
Yeah.
learned that because of this case that
Yeah.
there are
It
states out there
that just
where
it
you lose your
disregards like
rights.
it's
Yes.
insane. And what's
Yes.
scary is I mean, like I'm in the business, you're in the business, and that we didn't know this until like
Yes.
it's crazy. And
I
are
mean,
these things
I'm
common? No, but
assuming, I would hope that if you're in one of these states that you knew about it, but I don't know.
right. Yeah, I don't know. And I
Yeah.
just
Yeah.
it all boils down to just because you're pregnant, you somehow lose capacity or, and not talking about extreme cases, right? But in labor, you
Mhm.
can't consent or you can't listen or and I
Mhm.
just think
Mhm.
it is so it just explains how we view women in this country and
Right,
it's not
right.
great. It's not great.
Exactly,
Yeah.
exactly. I mean, that makes me think
Mhm.
of that famous, like, that quote, like, nothing about me without me, you know?
Right,
Um,
right.
and
Hmm.
I'm sure you saw the article that came out, I think in the past week, recently, about it's no wonder that fertility rates are
Yes.
further
I was
down
just looking at
further.
the bulletin, the digest, like probably 20 minutes before we started this. Yeah. Shocker. People don't want to
Yeah,
have babies when we can't afford it, when we see what's
exactly.
happening, when we can't
When
access
it's
healthcare.
riskier. Right,
Right.
right.
Yeah. I mean, if you want to
Exactly.
support families, it's not about just telling women to go off birth control. It's about all the other stuff.
Mhm.
Yeah, it's really not that complicated, right? But
Right, right. It seems
yeah.
logical to me. So that's
Yeah. Mhm.
yeah. So yeah, we are winding down, but I don't want to let you leave without your thoughts on women's pain
Oh,
and how we
yeah.
regard that. That's always something, we don't talk about enough. And so,
Hmm. Yeah. Well, I think that, so I'll give talks to med students or college students periodically about being an OB-GYN or just in general, the state of healthcare. And I love to use data to drive a point home. And when you
mhm,
see their faces and they go, oh my God. So when you show studies that have shown that when women go to the ED for a complaint versus a man, how long they wait, how likely
mhm,
they are to get pain medicine versus anti-anxiety medicine, how likely they are to be discharged during an active myocardial infarction as opposed to a
mhm,
man. And it's never good when it comes to the woman side of things. And so I think
mhm,
that, we know that, but it's like, what do we do with that? And I think it's just, it boils down to listening to women and believing women,
mhm,
whether it's, talking to them about options for pain medication for IUD insertion or gynecologic procedures,
mhm,
or respecting a woman who doesn't want anesthesia for labor and giving her other options and other continuous support. It's just about believing them and listening to them
mhm.
and not assuming that it's all in her head.
Yes.
Because I think that we have not been trained we've been trained and we need to undo a lot of things and
Mhm.
including with women's pain. And we can have these discussions in a way that is talking about evidence. Because what I see a lot on TikTok is IUD insertions are horrible and terrible. And the group that's not represented are the people who are like, well, actually, mine was okay. It was fine. Like, let's use data to guide us and say, well, this percentage of people will feel this and this will feel that. And here's what we can do. And just empower people to make choices.
I love that you link that with belief. Usually we talk about believing women in terms of sexual assault, but yeah, this is just a fundamental problem with any type of care or, concerns women have is we aren't believed. So believing women, that's such a
right. And not sugarcoating it when somebody's like, does labor hurt? And I'm like, kind of, yeah, it's gonna suck, as opposed to just a little pressure.
Right. Did you have any other thoughts to share that maybe I didn't touch upon or something else you'd like to, share about your book?
This was so fun. I just want to say thank you. You have asked it's just been great to bring all of these topics together and talk about them. And I really appreciate you giving voices, to folks where it's not going well and where we need to speak up and work more on that. So no, it's been so fun.
Yes, it's so fun to finally meet you, Jen. I hope you're coming out to the East Coast for a book tour or
so I was out there. I know I was out there briefly. Well, not briefly, but kind of briefly a week and a half ago. And then, I'm heading back. I'm heading to DC in a bit. So we'll see.
Wait,
who knows?
Are you going to ACOG?
Yes. Are you?
Oh my God, I'm going to bring my book so you can sign it.
Okay, I actually have I have a book event. I'm going to email you the invite to. Hopefully you'll be, okay. That'd be so fun.
Thrilled. Okay, and also if you come out to Boston and New York, I often I'm kind of a two-city person there.
Oh, so. Sweet. Oh,
sure. Actually, I have another question. I'm sorry.
Yeah.
Do you see another book? Do you see other projects? What are your other projects?
Oh my God. Okay. No more books. I'm so tired. So my husband's a pediatrician and I want him to write the next book of that, but he's, he's too busy.
What a great partnership. Oh my God.
I had a good time in residency. Cause during the stat C-section, when he was on the NICU rotation, I was like, there you go. So we had a good time.
Great.
But except for when I was pregnant twice, we were like, oh my God, peri-viability. Let's just get past it. Like both of us knew a little too much, but no other projects. So I have a podcast called Let's Talk About Birth, which is a limited 10 episode series to coincide with my book that came out. And it's been super fun just talking about different topics, whether it's, anesthesia or where to have your baby or what an OB hospitalist is. It's been really fun.
Okay, cool.
So and you can just, keep following me on my socials. So
can people find where your next appearances are? Like book your book?
Yeah, I would say you can sign up to my mailing list. That's on my website. And then that's the main one. And then just keep an eye out on social media. So yeah.
Okay. And what are your handles? Do you want to share where to find you?
At Dr. Jennifer Lincoln. It's a DR instead of the full doctor, because that'd be too long. And that's pretty much all of them. That's, all of them.
Thank you so much for joining me.
Yeah, thanks for having me.
Bye. Here's my closing thought for today. In the patriarchy, the labor and delivery experience often disempowers women by over-medicalizing care, not involving women in decision-making, and by minimizing their pain. In the Gynarchy, we feel that childbirth needs to return to becoming a more woman-centered experience, emphasizing education, informed consent, women's autonomy, and their agency with regards to decision-making about their care. So down with the patriarchy and up with the Gynarchy. Thank you so much for listening. If you've enjoyed this episode, please consider leaving us a review on one of the podcast platforms. Take care. Did you enjoy this episode of the Gynarchy Podcast? Know someone else who might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Blue Sky, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.